I want to explain why this new legislation is not a step in the right direction. A lot of us who hoped for reform thought we might get a partial movement towards really good coverage and that we could build on it, but that's not the case with this. And then I want to talk to you about a way that we can fix it where we can all actually get good quality and affordable health care coverage. So we're supposed to have more access with this plan, but access to what? So this is still going to be employer-based. So the employer is really going to decide who your insurance contract is going to be available with. The one way that insurers get around paying money is that they'll set terms for a contract that are unacceptable to a lot of doctors. Some interesting things with the exchanges and even the employer-based plans, that there are levels of coverage. So you can be a bronze person or you can be all the way up to a platinum person. Even the bronze plan has to offer some minimum benefits. We'll get to that in a minute. But your amount that you have to pay out of pocket varies significantly between those plans. You can get subsidies. But after 2017, the premiums can be higher than 9.5% of your income if the insurance premiums rise higher than the consumer price index. So that means that if insurers raise their rates higher than the other cost of living increases, that they can charge you higher premiums. So I'm not sure how that really controls your premium. So one of the things that some people in this healthcare reform controversy have talked about is that we need more cost sharing, that we should have to pay more when we go to the doctor to make sure that we only go when we need to go. But this is what happens. We don't go when we need to go and when we don't need to go, and then we wind up in the hospital. So it's just not a very effective cost-saving strategy because the hospital days are more expensive than the outpatient visit. As employer-based plans, if the employees wind up having to pay too much, the employer can be penalized. But that can be adjusted by the age and the gender of the employees. So if they have a lot of women, they decide we're more expensive because of having babies and so on, and if they have older people, then they are not going to be penalized if they have higher premiums. All these premium thresholds and a lot of the reforms don't apply to grandfathered plans, and the grandfathered plans are the ones that we have. So most of this stuff only applies to new policies, and I feel sure that they'll figure out some way to keep these grandfathered plans around as long as they can. Picking. Now, they're not supposed to be able to deny you access anymore for pre-existing conditions when this fully takes effect. But they have ways. They have ways of doing that. They throw administrative roadblocks. They lose your paperwork. I had an experience with a family member where we had to qualify for continuing coverage, and it took me 3 months for them to get this simple one-page back-and-front form. I faxed it, and they didn't get it. I mailed it, and they only got 1 page, and I said, how is that possible? It's a front and back page. I thought I was going to have to drive down out to another city and hand them this page, but after 3 months we finally got it. So they really do things like that. If you have a condition that's going to be expensive, they'll so no lifetime or annual limits. But here's a good one. It shall not be construed to prevent health insurance coverage from placing annual or lifetime per beneficiary limits on specific covered benefits that are not essential health benefits under Section 1302B. So there are ways they can do limits, and so they might decide, like short stature, they do that. So there may be limits on some things. I'm going to spend a lot of time on this, but there are 23 million people that will not be covered, and there are different ways of lopping off big sections of this 23 million if you decide you don't like something or other about them, and you just sort of whittle it down so they're not there anymore. But the problem is they're still expensive because they're going to be at the emergency room. It's going to cost. So in reading this law, I keep running across the word reasonable. That is a scary word to me. I'd be scary to any lawyers in here. You know what reasonable means? Is reasonable means you got a good court. Nobody knows what reasonable means. So there are reasonable words, like as we said, for annual limits, premium increases, that's supposed to be unreasonable, overhead percentages, out-of-pocket costs. The government is going to be subsidizing private insurers with our tax money. And, you know, I resent that. I resent that I'm going to be forced to buy what I consider to be a defective product, and I'm not going to have any choice in that, or I'm going to have to pay a fine. This is bad. There's a decreased dish payment. This is a disproportionate share hospital payment. So these are payments to hospitals that they call safety net hospitals. They take care of a lot of poor people. And they were getting this extra money to keep them afloat. Well, they're not going to pay them as much under this new law because they think everybody's going to be covered, but that's not going to, that's bad. Y'all. The nurse that your doctor's office calls to get your CT scan approved, because we have to get a pre-approval if we think somebody's got a brain tumor, we have to call first. The nurse that they talk to that then says, no, you don't really have a problem. It doesn't sound that bad to me. I'm not going to give you a CT scan. She's now a medical expense. So cool, they're shifting their administrative costs over to a medical expense. We really can't have good quality of care unless we all have access to any good provider or any provider. And then what happens is people are competing on quality. The good docs will get filled up, the bad docs might go out of business. And I hate to say it, and I would never name names, but there's some docs out there who are not so good. And if that's the only people you can go to in your policy, you're stuck. We do all get covered. There's going to be difficulty. We're going to need more physician extenders like nurse practitioners, and we're really going to have to crank out some good doctors. Okay, so what's a better solution? Take these private, expensive insurance corporation people out. They don't belong in healthcare. They're in the way. People in countries with universal health care, all the other developed countries in the world live longer and they're healthier. This is the potential years of life lost per 100 people for all causes. And look how much higher that is in the United States. It does not have to be that way. We have good doctors here. We have good hospitals. We can do a good job. We're not doing as good a job as we could, but we can. But the failure to have adequate insurance system is largely responsible for that big yellow bar. Okay, so comprehensive. Let's cover all body parts. Let's don't leave out our jaw or some weird thing just because they decide they don't like it. People are spending too much money on that body part, so let's don't count it. So dental, hearing, vision, mental illness. Your brain's a real important part of your body. Some of us worry that we're not going to be able to get anything decent like this until we have campaign financing reform, so that they have to listen to voters. We went through kind of what I call the pictures of the tantrum phase in the town hall meetings last year. Maybe we'll get to the teenager phase in a few years, but we were yelling and stomping our feet and not really getting anywhere. Because I think we are out of the habit of participating in civic life. We think we can read the paper and go and vote and that we're done, but it will never ever work that way. We have to pay attention. When I say publicly financed, I mean we're all going together to use our money wisely. I'm not saying that it's a free ride for anybody, and I think we need to be careful that we use the right wording for that. Now, if the evidence is that something does not work, it doesn't matter if it's cheaper, we shouldn't be giving our money to it. Remember, this is our money and it's not free.